give a little bit of a brief overview on some of these key signaling pathways that are currently being targeted in the treatment of muscular dystrophies and their role in the disease progression.
Sure. I mean, it's a little bit of a complex question, but I'll try to give you like the 30,000 foot overview. There's a big interest right now in blocking fibrosis as kind of a general mechanism. So a lot of the muscular dystrophies, the limb-girdle muscular dystrophies, Duchenne, which is what I study and which my lab is really focused on, fibrosis occurs predominantly in the skeletal muscle, but also in the heart and the lung. And so there are many different companies approaching it to where if they can block or inhibit fibrosis using small molecules, using other types of inhibitors, neutralizing antibodies. They seem to show a lot of benefit in animal models, and now a lot of these companies are now taking them to the clinic. So it's really exciting in terms of a general mechanism to block fibrosis. There are other kind of pathways that are focused on stabilizing the myofiber membrane. Some of these are physical-based polymer compounds that can essentially seal, or I should say kind of block the degradation of things such as the dystrophin-associated complex. And the thought process is if you make the muscle stronger, more tight, it's less likely to leak calcium, less likely to cause like immune signaling and the cytokine storm in a lot of diseases that basically will keep driving pathogenesis in a lot of these muscular dystrophies.
So what are some of the major challenges that clinicians face when targeting signaling pathways in muscular dystrophies, and how are we working to overcome some of these challenges?
Sure, it's kind of a complex question. I'll start off by all the muscular dystrophies are not the same. Even within ones that are characterized with the same same gene-based mutations, we're finding that they can have a variable spectrum of symptoms. Again, as mentioned, I work with Duchenne muscular dystrophy, and it really depends on where the mutation's at. So there are common mutations that occur around certain portions of the gene, but there are also uncommon ones as well. And there's some that basically result in milder phenotypes where the patients can walk a little bit later, past 13. Others are much more severe. We're also finding out that there are a lot of secondary mutations too, modifier genes. There's a really keen interest both in the academic side and the drug development side in finding genetic modifiers that may hopefully be new drug targets so that they can basically slow the disease progression. So in terms of complexity, that's a big kind of challenge that we face as a field. Characterizing all these mutations, which we've done a better job now with things like whole genome and whole exome sequencing, but also really from a personal perspective or I should say precision perspective, not every patient is going to respond the same. And so it's really important to do a really good workup of the patient ahead of time, looking at not just the skeletal muscle, looking at liver, looking at cardiac function. And so I think these are key considerations. And for any drug, whether it be a small molecule or a gene therapy viral vector.